2 more sections, and then we'll call it. All right. So this is part 1 of our anatomy of the abdomen, and we are doing the abdomen because there's just so many connecting structures that are important to note. So we'll go through this part 1 and then part 2, then we'll take a 10, and then we'll go into the embryology section at the end. These are the muscles of the anterior lateral abdominal wall. Paying attention here to we have our external oblique, our internal obliques, our transverse abdominis, and then the front, our rectus abdominis. Again, recognizing our innervation and actions as our important components, the most important. The beauty of this is our thoracoabdominal nerve and is the main nerve that's innervating all 3 of them. But we can see that there is some differences here between the 2. Our external oblique has the subcostal nerve as well. The internal oblique and transverse abdominis have the first lumbar nerve, and the rectus abdominis just has our thoracoabdominal nerves, but it's kind of slightly different rami than the others here. Then if we look at what they're doing, our external and internal obliques are compressing and supporting our abdominal organs, and as well as flexing and rotating our trunk. Our transverse abdominis is compressing and supporting our viscera, and our rectus is our big flexor. Think like your crunches, your sit-up muscle, right? Helping you get that 6-pack. If we look at them here in a different view, we can kind of see the rectus abdominis better. But these 3 flat muscles will end anteriorly in an aponeurosis that forms this tough rectus sheath that encloses the rectus abdominis. And the aponeurosis interweaves, forming this midline raphe, which the linea alba, which extends all the way up from our xiphoid. There we go, xiphoid, all the way down to our pubic symphysis. And this is what can get torn in conditions like pregnancy. The fibers of the rectus abdominis run between the tree or the more tendinous intersections or inscriptions. And you won't always see this, but sometimes you'll see these pyramidalis, and it ends and tenses the linea alba, but not everyone has it, so I wouldn't probably pay attention to it. Really know the 4 muscles here. Know the linea alba. It comes from that aponeuroses from those muscles. In regards to rectus abdominis, what's the important piece here? This is aponeuroses. This is just talking about the sheaths. I think that's pretty self-explanatory. Okay, our nerves. So our nerves of our abdominal wall. We have our thoracoabdominal nerves, T7 through 11, innervating our rectus abdominis muscle and the skin itself. So both those pieces, having a sensory and a motor component. Our subcostal nerve, the large anterior rami of the spinal nerve 12, we saw that that's going to innervate, if we go back to our picture here, the external oblique specifically. And our iliohypogastric and ilioinguinal nerves, we haven't talked about those specifically yet. They're branches of the anterior rami of L1, together with the subcostal, supply the skin inferior to the umbilicus with its innervation. Okay, so important to kind of keep note. Down below the belly button or umbilicus, we have a different innervation superficially to our skin. Looking at our superficial abdominal vessels for the anterior abdominal wall, we can see we have superior epigastric vessels, which are branches kind of up top. I don't know if I have a great view. Let me see if I can actually take this out for a second and uncrop it. Yeah. Here we go. This will be actually much more beneficial. Magic. Okay. There we go. So our superior epigastric vessels, we have our superior epigastric artery up here. These are branches. They have the musculophrenic vessels and then our internal thoracic vessels. So we have our internal thoracic artery, branches into our musculophrenic and our superior epigastric. And again, these are all the branches or the vessels of the superior or the anterior and lateral portion of the abdominal wall, but they are also superficial. We are not talking about the deep arteries that are innervating our organs, right? We're really superficial at this point. We can go all the way down at the bottom, down here, and I think I'll be able to find our inferior. Yep. Right here, our inferior epigastric, kind of coming up and communicating with our superior epigastric, and our deep circumflex arteries, so deep circumflex iliac arteries or vessels are going to come from our external iliac vessel all the way down here, external iliac artery. And then we have from our femoral artery, which we can see kind of, there's femoral, sorry. External iliac is here. Femoral, I guess, yeah, there you go. Off of the femoral artery, so prior to the external iliac, it's really small, so I'm trying to read it. You can see, so prior to we get to our external iliac, when we're at our femoral, you can see that we have our superficial circumflex iliac and our superficial epigastric vessels that will come off our femoral artery. So we have our superficial circumflex artery here, and we have our superficial epigastric here coming off the femoral artery prior to when we see up here, it's our external iliac. So external iliac passes through the sheath, femoral. These two branches would count as being branched from the femoral. These two branches would be considered branched from our external iliac. Okay, so kind of separating the two pieces there. All right. Whew, we got through it. Looking at the peritoneum and peritoneal cavity, I think this is probably more high yield than those vessels, to be honest with you. But the parietal peritoneum is going to line our internal surface of this abdominal pelvic wall. So kind of going a little bit step deeper. Our intraperitoneal organs are almost completely covered with our visceral peritoneum, that fibrous sheath that covers each of our organs, visceral viscera, and our extraperitoneal, retroperitoneal, and subperitoneal organs are outside the peritoneal cavity, and most of them just have one layer of peritoneum on the side facing whatever cavity that they're next to. The peritoneal cavity is closed in males. It's not closed in females, obviously, because we have other structures that are formed there that we have to utilize. We have other organs present. We can see kind of some of these structures here. So we can see the peritoneal cavity up here, and then we can see the organs posterior to it, really our kidneys on the other side. When we look at our peritoneal vessels and nerves, the parietal peritoneum is served by the same blood and lymphatic flow as the abdominal pelvic wall. So those muscles, that wall piece, those vessels are going to serve our parietal peritoneum. The whole surface as a whole is sensitive to pain, pressure, heat, cold. And it's more localized versus our visceral peritoneum has the same blood and lymphatic vasculature as the organ it covers, and therefore it's insensitive to touch, heat, cold, and laceration. So we have kind of a challenge in being able to always identify where the pain is occurring when it's coming from an organ. That's why we have those referral patterns for pain that we're sometimes utilizing to identify where are those pain points within the body, within the abdominal region. A couple other connective tissue structures that get a lot more play on NPLEX-like exam is our greater and our lesser omentum. So when we look at our greater omentum, we can see this picture here, greater omentum containing our gastrophrenic, our gastrosplenic, and our gastrocolic ligament. Our lesser omentum containing our hepatoduodenal and our hepatogastric ligament. They're coming off of the either greater curvature of the stomach or the lesser curvature of the stomach. So when we look here, we can see that the greater omentum extends from our greater curvature of the stomach. It has an proximal duodenum, and there's 3 parts, and you can kind of see where those 3 parts are located from. The lesser omentum from the lesser curvature of the stomach is really connecting the stomach, that part of the curvature, the duodenum, to the liver. And then another ligament that we don't want to miss from its special component, besides being a part of the lesser omentum, is the hepatoduodenal ligament. Also connects the portal triads together, which is an important component that it has. When we look at how we can break up this peritoneal cavity into different structures, we can divide it into a greater sac and a momental bursa. And so what you're doing here is you're taking this sac here, you're kind of pulling things up. You see the lesser sac here. We're essentially trying to separate things, but based off of where they fall from that greater or lesser omentum. So our omental bursa, it would be our lesser sac. This is the smaller portion of the peritoneal cavity that is posterior to the stomach. It allows for kind of free movement of the stomach to have these two omentums essentially, or a superior and an inferior portion. The omental bursa is able to communicate though with the greater sac via a foramen. And so it does allow for communication between the two. So there's not just complete separation of contents from one versus the other, but it is the way that we're able to kind of separate out components of the abdomen. And for surgeons specifically, it's helpful to know kind of which sac or portion you're cutting and operating into. Not so important for us naturopathically, although from like a functional phys med perspective, it can help understanding the different ligamentous structures present. From an anatomical perspective, looking at the stomach, we have a couple different components that we want to care about. So starting from the top, our esophagus is going to lead into our cardia area. This is where the cardial orifice is, the opening of the esophagus into the stomach. Up at the most superior region is our fundus, which actually reaches the fifth intercostal space, which we know about the fifth and fourth intercostal space when we're auscultating the heart, right? We auscultate in the fourth intercostal space, and the fifth intercostal space right below is actually what our stomach reaches up to in that chest wall. The cardiac notch is the separation between the esophagus and the fundus. It provides a space here. We then have the large portion of the body that creates our lesser and greater curvature. Towards the end, we have the pyloric region of the stomach, which is more of a funnel shape. The wide portion is the pyloric antrum. It leads to the pyloric canal, which starts to narrow. And then the pylorus, or the pyloric sphincter, which is where then that is controlled based off of if there's food coming into the stomach and if we are done with digestion and ready to move into the duodenum, the first portion of our small intestine. If we look inside the stomach, we'll see from microscopic view gastric folds or rugae, and those are extensively present when the stomach is contracting. We'll also see a gastric canal or furrow that can form temporarily when swallowing that will occur between the gastric folds, specifically along the lesser curvature, allowing small amounts of fluid to pass through the gastric canal to the pyloric canal when the stomach is, for the most part, empty. Prevents us from having fluid overload or buildup from the stomach without having a big food bolus come through. Vascularity of the stomach wise, our celiac trunk from our foregut developmentally is the main kind of feeder of blood to the stomach, but it's not the only one. The majority of the stomach is supplied by anastomoses formed along the lesser curvature by the gastric arteries, both right and left, and along the greater curvature by the gastroomental arteries. So those are kind of your big players. And we can see this here, our left gastroomentum artery here, and then our right gastroomental artery here along that great curvature. On the lesser curvature, we can see the gastric artery, the left gastric artery here, and the right gastric artery here, supplying blood supply to the stomach. The celiac trunk is where all of these branched off of. So that's kind of where we came off of essentially the abdominal aorta and then branched into these different sub-trunks. The fundus itself might receive a little bit of, might receive short and posterior gastric artery supplies, which are branches of the splenic artery. So you may have a little bit of communication with the splenic artery to the stomach, but for the most part, think gastric arteries, lesser curvature, gastroomental arteries as the greater curvature, all arising from the celiac trunk. When it comes to venous drainage, the left and right gastric veins drain into the portal vein. Short gastric veins in the left gastroomental vein drain into the splenic vein, which joins our superior mesenteric vein to form the portal veins. And the right gastroomental vein usually empties into the superior mesenteric vein directly. It doesn't need to kind of join together. So that's your pattern of drainage, all things going back to that big portal vein at the end. Innervation-wise, parasympathetic supply is from our anterior and posterior vagal trunks, so the vagus nerve, cranial nerve 10. Sympathetic nerve supply comes from our sympathetic chain, specifically T6 through T9. They'll pass through the celiac plexus via the greater splanchnic nerve, and it'll be distributed more as a plexus around the gastric and gastroomental arteries. Remember, parasympathetic stimulation to the stomach can actually stimulate the processes of digestion. versus sympathetic nerve supply is really focusing on vascular supply because there's not any necessarily direct innervation from the sympathetic nervous system to the stomach. So when we have sympathetic stimuli to our digestive organs, it's really shunting blood flow away from the stomach during times of increased sympathetic stress, saying, hey, we don't want to digest right now, so I'm not going to give you as much blood supply, so you can't do the work of digestion as well. That's really what our sympathetic nerve stimulation is doing. Moving from the stomach, we move directly into our small intestine. We start with the duodenum. This is the first section that we'll hit first. Really, there's kind of different portions that you need to know. I wouldn't care about superior, descending, horizontal, ascending. Just recognize it's the first portion of the small intestine that you are going to reach. The first portion of duodenum is intraperitoneal. And then the fourth portion moves from retroperitoneal to intraperitoneal. So that I think would be the only most important thing, is to recognize that we start and we end in the intraperitoneal cavity, but the fourth portion does have to go from the back essentially up front. So that would be, I guess, the most exciting component about just generally the structure of the duodenum. Looking at the small intestine from more of a histologic standpoint, or looking at it closer together, we can see that we look at kind of the next two phases, the jejunum and the ileum. They are going to have slight different structures. The circular folds of the jejunum are increasing surface area a lot more than the circular folds of the ileum, but they are both still present there. And both of them have the vasa recta, which is really just representative of small capillaries that are forming almost a mesh over these organ structures, allowing for exchange of nutrients, like picking up these digestive components from our small intestine. Because remember, internally, our small intestine has our brush border and our brush border enzymes. And our whole goal in our small intestine is to do the final components of digestion and then absorb it through that brush border into our cells, our epithelial cells, and then pass those pieces through into our blood. And so vasa recta is where a lot of that pickup occurs, in those capillary spaces. We'll look more at the process of digestion and absorption when we get into physiology in 2 weeks. Then lastly, we end into our large intestine, going down to our cecum. So we went from our duodenum to our jejunum to our ileum, and then we're going to reach essentially the kind of last portion here. So we have our ileum here, moving to our cecum, then our ascending, our transverse, and our descending, our sigmoid, which is like the S curve, and then into our rectum. So that's our process here in our order. If we're looking at arterial blood supply here, let's see, what are the most important pieces for us to care about? The cecum is supplied by our ileocolic artery, which is a branch of our superior mesenteric. The appendix is given its own artery, the appendicular artery, which is a branch of the ileocolic. So it's a branch off of this artery here. And then the ileocolic vein is a tributary of the superior mesenteric vein, and it will drain both these regions. Why do we care? Because if the appendix gets inflamed or irritated, it's important for us to be able to recognize kind of where that drainage pattern could occur. Also, the appendix as an organ is often a housing space for our healthy gut bacteria, our healthy gut flora. And so we can kind of see where that communication pattern could be from a blood supply piece, although it's directly seeding via our digestive tract. It's not going through the blood. A couple of different like components internally. We can't really see this here, but haustra and omental appendices. Really, the haustra are those these like outpouchings here. And then we have the tinea coli, and it allows for that kind of contraction, that peristaltic contraction, to allow things to move forward throughout our digestive tract. Our flexures are hepatic flexures by our liver, our splenic flexures by our spleen. When we're thinking about where things are going, both the ascending and descending colons are retroperitoneal, so they're kind of in that back portion. And I think and then the transverse colon kind of comes intraperitoneal, so we can see it comes forward here. Excuse me. All right. Looking at our descending colon, moving down into our sigmoid colon and our rectum, or recto-sigmoid junction. I think the most exciting portion of this is just making sure you have the order correctly. Looking at the blood vessels of the descending and the sigmoid colon, we can see the arterial supply here is from our left colic and sigmoid arteries, which are branches of that inferior mesenteric artery. These arteries pass to the left where they start to divide and branch off, and we can kind of see how there's all these like branch points across here, almost like a spider web here. You can also see similarly to our venous side, the inferior mesenteric vein is going to be the big vein that's returning blood from the sigmoid and the descending colon. It'll typically bring it up to the splenic vein, and then it'll go directly into portal circulation. Speaking of the spleen is surrounded by peritoneum, except at the hilum being kind of this portion here. It's surrounded by splenic branches of the splenic artery, which provides its arterial supply. And it's pretty high up in that costodiaphragmatic recess, but it is separated from the diaphragm, and it can vary in size greatly. It typically is very retroperitoneal, so it's contracting the posterior wall of the stomach, and it's also connected to the greater curvature by our gastrosplenic ligament, and to the left kidney by our splenorenal ligament. These ligaments contain the splenic vessels. That's kind of how these pieces are connected. And we can see here some different areas and what these different bodies mean: superior border, inferior border, and kind of the anterior extremity portion. So looking at our spleen here, this is our aorta, this is our pancreas, right? So getting an idea of what we're looking at. So the hilum of the spleen is in contact often with the tail of the pancreas. We can see that here. It's supplied by the largest branch of the celiac trunk, which is the splenic artery. It's a great words question. And we can see, though, that there's multiple different branches of this artery that will enter into the hilum and divide into multiple different segments. So yes, it's not just one artery, it's branching off in here. And we can see also the relationship between our vasculature of the splenic artery and the vasculature that's going to eventually communicate with our pancreas here. So we can see from this common celiac artery, the splenic artery, the celiac branch, and then if we track this over here, we have our common hepatic, our gastroduodenal, and then our right gastroomental artery. And then we have this wrapping around, we start to get our pancreatic arteries here that are dividing and wrapping around our pancreas. We'll look at our pancreas a little bit more in a moment. We talk about splenic drainage. Our splenic vein is going to join up with our inferior mesenteric vein, and it's going to run posterior to the body and the tail of the pancreas. Back here, it'll unite with our superior mesenteric vein to form our portal vein. So now looking at the pancreas as a whole, so this little pancreatic structure, and then our small intestine, and then these big arteries and veins running through. The tail is going to be intraperitoneal. The rest is retroperitoneal. So it's why it's hard to view on imaging. And the head kind of hides in the C-loop of our duodenum. The uncinate process is going to project from the inferior portion of the head. So we can see this portion A here, posteriorly to the SMA and the SMV, so superior mesenteric artery and vein. The neck is going to overlie the superior mesenteric artery and vein, and there's like actually a groove for them to pass on that posterior side. And then the body is here, and then the tail is at the end. It's pretty mobile. It's intraperitoneal, and it'll pass kind of through the layers of the splenorenal ligament with the splenic vessels. Again, not physiology, so we're just focusing on anatomy. That's why I'm kind of just focusing on the structure. If we look at the ducts of the pancreas, we have a couple ducts we want to pay attention to. The common bile duct, which is located here in green to represent our gallbladder, and the pancreatic duct, which is kind of the main pancreatic duct here, are going to combine together and form this short, kind of dilated hepatopancreatic ampulla, which is their combination here. It's going to open at the major duodenal papilla in the duodenum, and the sphincter of the bile duct and hepatopancreatic sphincter is called the sphincter of Oddi, and that's located right here. That's the major control sphincter that is controlling the release of pancreatic juice and bile. And this is controlled hormonally, which we will look at. Now, the accessory pancreatic duct, this little tiny one here, we often see it as the accessory duct now. It's going to drain the incident process and opens directly into the duodenum at the minor duodenal papilla. And this allows for really a release of a couple different things, but one of those things is bicarb to help neutralize the acidic components of the stomach as they enter into the duodenum to make sure that we're not damaging that small intestine. All right, that was just part one. I'm going to go into part two, and then we'll open for questions and take a break. But I wanted to talk about our liver. So going directly from the pancreas and the gallbladder, which we started to talk about, our other structure in that right upper quadrant is going to be our liver. And so we'll look at the lobes and segments of the liver. There's 4 lobes, but only by surface appearance. Functionally, in terms of blood supply, it's really divided into right and left liver portal lobes. The right and the left lobes are separated by the falciform ligament and the left sagittal fissure. So if we see here, I don't know if this is the right sagittal fissure. I'm gonna see if I have it labeled on here for you. I may have it in another picture. Yeah, this is a different picture that shows kind of the breakdown of the liver pieces. When we look at our different lobe components though, like this would be our left lobe, this is our right lobe, but technically the caudate and quadrate lobe are counted as a part of the right lobe, even though posteriorly we view them as kind of separate components or separate lobes here. This is the posterior inferior view on both of these sides. This just has an overlay of vasculature and where the gallbladder is sitting. Our left sagittal fissure is a groove formed by the fissure for the round ligament, ligamentum teres, which I believe we can see maybe, oh no, drat. Sorry, I'll need to get a better picture next time I do this slide. And then posteriorly via the ligamentum venosum. Oh, maybe that's why. Oh yeah, here we go, because we're posterior. So ligamentum venosum here. There we go. Left sagittal fissure. And then the division between the right and left side of the liver is an imaginary line. Let's pretend. So breaking it down further, we can break it down into portal lobes, right and left, and we can break them down into components that have their own blood supply from a hepatic artery and a portal vein, and they have their own venous and own biliary drainage. These portal lobes are subdivided into 8 separate segments. So that's what you're seeing here is kind of the 8 separate lobe segments that contain their own artery, vein, and drainage processes. There are intrasegmental veins that are communicating between these different segments, and then they'll further demarcate on their way into the IVC, or inferior vena cava. And then if we look, we can see that the right, intermediate, middle, and left hepatic vein drains parts of these adjacent segments. And so all of these components of our liver, if we look at them as a whole, this is our IVC, our right hepatic vein, left and middle hepatic veins. All of them are getting their own kind of venous and arterial supply, but our venous supply is all coming back to the IVC at the end. Our arterial supply and our I guess the juices, digestive juices supply are all combining together in this portal triad, which is our hepatic portal vein, this big vein coming in, our hepatic artery, and then our bile duct. And so we can see kind of this classic picture of these structures here. When we are looking at actual vasculature further and nerves of the liver receives blood, not bolds, from 2 sources, the portal vein and the hepatic artery. Portal vein is by far where it receives blood the most from. So we're getting a lot more blood coming in, venous blood, than we are getting arterial blood, but it does receive both. The nerves of the liver derive from our hepatic liver nerve plexus, and it's the largest derivative of our celiac plexus. It will move with the hepatic artery and portal vein. Sympathetic fibers from our celiac plexus and parasympathetic fibers from the anterior and posterior vagal trunks are the 2 big pieces of innervation here. Combining then the biliary ducts and the gallbladder with these structures, remember, gallbladder is going to be the storage space for bile, but the liver produces bile. So that's key. Such a common NPLEX question. Don't confuse yourself. So our hepatocytes, our liver cells, secrete bile into the bile caniculi formed between them, those canals. Those drain into intralobular biliary ducts and then into the large collecting bile ducts of our between hepatic liver portal triad, which will merge to become the right and left hepatic ducts, which then drain the right and left portal lobes. And that's what we're seeing here. Okay, so small and small and small ducts all get bigger and bigger and bigger until they get to the right and left hepatic ducts, the collection of all the stuff from the right lobe, all the stuff from the left lobe of the liver, they combine together to create the common bile duct, okay? Or the common hepatic duct, which we see here, common hepatic, coming from the liver, common, all the liver stuff in one space. Then from the gallbladder, we have just our fundus body neck of a gallbladder, not something too exciting, but our gallbladder has its own duct, the cystic duct. And when the cystic plus the common duct combine together, that's when we get the common bile duct. That's the formation. So our bile duct, we can kind of see this on the left side of the descending duodenum. It will meet up with our main pancreatic duct. So our common bile duct meeting up with the main pancreatic duct. They will then unite to form that hepato, liver, pancreatic, pancreas, ampulla. And then from here, they will release via its sphincter of Oddi into the duodenum. And that's kind of where, again, how we meet up and combine liver, gallbladder, pancreas, all for the purpose of digestion. The only piece about the gallbladder, I think, that is, besides just knowing there's a fundus, a body, and a neck, and then obviously the different ductal, the cystic duct combining with the common hepatic for the bile duct, just don't say that the gallbladder creates bile. That's my big piece. Fueling the gallbladder, giving it blood, is the cystic artery, which arises from our right hepatic, and then cystic veins drain the biliary duct through the neck of the gallbladder. The fundus in the body will drain into hepatic sinusoids as a part of the liver. Innervation-wise, the celiac plexus, which is our sympathetic as well as pain, like viscera, innervate, and then the vagus nerve is giving it the parasympathetic component, and a little bit from the right phrenic nerve, which is, again, somatic afferent fibers, sending signals back to the brain that something's not right. Okay. Our portal drainage system, we've kind of spoken about this a bit more, but I wanted to spend a moment on kidneys. Kidneys are the most retroperitoneal structure we've talked about so far. They lie literally on the posterior abdominal wall, located between T12 and L3. Remember that the kidneys aren't exactly at the same height. The right kidney is slightly lower than the left kidney because of the liver. The liver takes up a lot of space here. Our ureters then are going to move downward here, and they are going to run over kind of the pelvic brim at the bifurcation of the common iliac arteries. So kind of where these arteries bifurcate, that's when the ureter is going to run over. I did want to mention the renal hilum. The renal hilum is where you will lead into the renal sinus. You have your renal artery and vein that are moving into that hilum of your kidney. This is where your adrenal glands sit on top of the kidney at the superior pole. You have your lateral margin, obviously, here. Inside, that's where you have your renal sinus, emptying into your renal pelvis, which empties into your ureter. If we open up our kidneys, we'll look closely at the actual tubes when we go into physiology. But when we look here, you can see the inside, we have our renal pelvis, which will collect urine. We have our major calyx and our minor calyx, where urine drains into. And then in our at the top of our calyxes, we'll see our actual renal pyramids, these structures here, separating out from our medulla and our cortex, our different structures. So medulla of kidney, cortex of kidney. Similar to adrenal cortex, adrenal medulla. Vasculature-wise, our renal arteries come off of essentially the disc between L1 and L2. So you can see them coming off of our aorta around that region. The right renal artery goes posterior to the IVC, therefore it's longer. And then within the hilum, they're dividing multiple times. More on renal vasculature, there's a couple different arteries that we can look at. The renal artery is going to be the biggest blood supply, but we'll also see that our renal arteries come from 3 different sources. We have superior suprarenal, middle suprarenal and inferior suprarenal arteries. Are these super duper high yield? I'd say they're much less high yield than understanding where the renal artery itself comes off of the aorta. That's what I'd focus on at this point. Innervation comes from our renal nerve plexus, which has sympathetic and parasympathetic input, as well as visceral afferent signals sending up to the brain, telling us if something's wrong, like pyelonephritis. It's how we can feel it, because there's visceral afferent fibers. The renal plexus gets fibers from our abdominal pelvic cavity and the splanchnic nerves. Those are the biggest pieces of the puzzle there for innervation. This is the whole summary slide. I think this is like way more confusing than it's helpful. Same here, way more confusing than it's helpful. It's just showing the connection between the splanchnic nerves and like where they're innervating specifically. I would say lower yield at this point. Vagus nerve's great. That one's easy for parasympathetic innervation. But if we are going to talk about parasympathetic components, I do think this one's more important than sympathetic just because we can name it. We do have our vagal trunks. Our pelvis splanchnic nerves has nothing to do with our sympathetic trunk. And then our abdominal autonomic nerve plexus, and then the intrinsic parasympathetic ganglia. These would be like the innervation pieces from the parasympathetic chain, vagus being the biggest, obviously, innervator of our gut. Again, more plexi. If you would like to look through these, if you feel like you have the branches of the abdominal aorta down, you know your cranial nerves, and you're looking for something else to memorize, go for this slide for all the different plexes. I think it's low yield for what you're going to be looking at for your test. I wanted to just show diaphragm, just kind of where we are, just so we could have an idea of where we are, like essentially in like the different opening pieces. These are often questions. So our aortic hiatus, that opening where the aorta flows through, is at T12. The aorta, the azygous vein, and thoracic duct all flow through the aortic hiatus. The esophageal hiatus is at T10. Our esophagus, vagal trunks, and the esophageal branches of left gastric vessels, as well as some lymph stuff, pass through here. And then our caval opening is T8. This is where your inferior vena cava, the terminal branches of the right phrenic nerve, and some lymphatics also flow through. So these three things, that would be the only pieces I'd focus on here for this slide. When it comes to our vasculature of the diaphragm, we have inferior phrenic arteries as being some of the main players, and then inferior phrenic veins. And this is the fascia. I'm kind of moving through these pieces. Okay. Looking at some muscles then, we've talked about our superficial muscles and the muscles wrapping around. There are a few muscles of the posterior abdominal wall. The psoas major and minor are two of those. Psoas major comes from our nerve roots of lumbar 1 through 4. Psoas minor only gets L1, so that's a good distinction point. And for our actions, it's going to help with lateral flexion of the vertebral column and to flex also the femur at the hip. That's our psoas major. Our psoas minor is just going to be a weak flexor of the lumbar spine. It's not going to provide a lot of support there. The iliacus is innervated by our femoral nerve and helps to flex our femur. And then our quadratus lumborum is that thick muscle in the back. We can see this posteriorly here. This is innervated by our branches of T12 and L1 through 4, and it will help with extension and lateral flexion of the spine. We're skipping those nerves. This kind of gives you an overall picture. Again, I think low yield because we want to look for a moment at our lumbar plexus. So lumbar plexus, like all of our other plexi that we've looked at so far, I would say this is the least important of the ones that we've looked at thus far, but we'll still just have a moment to pay attention to it. Our ventral rami, the things coming off the spinal cord, are labeled at the region that they're coming off, right? So L1 through S4, and these are coming below the actual vertebrae body that they're associated with. So we'll see L1 will be coming below lumbar 1, L2 below lumbar 2, et cetera, et cetera. We'll see they'll combine together and form all these different tracts and components. And if we look at, okay, what's the femoral nerve come from? Femoral nerve being here, it's going to come from L2, 3, and 4. Obturator, again, 2, 3, and 4 as well. Other ones that are important is down below are sciatic, which we've looked at already. We can see sciatic coming from both common and then breaking down to common fibular and tibial, but really coming from L4 through pretty much S3 for our sciatic. And then these other nerves are more smaller nerves I wouldn't worry about as much. Sacral plexus, I think, is more high yield than lumbar plexus outside of femoral and obturator, knowing those sources. And this shows you where they innervate. Vasculature, if you've been totally lost when I've been talking about vasculature of everything, I understand it's confusing. Here's some other pictures that may help because these ones I think are better. Sometimes that's summing things up. I'm just gonna honestly, well, we'll look at this one first. So if we look at our aorta here, we can see this bifurcation of the aorta into our right and left common iliac arteries. From there, our right and left common iliac arteries branch into our internal iliac artery and our external iliac artery. The external iliac artery will become the femoral once it passes through that kind of inguinal canal and gets to the other side. Off of our external iliac artery before it becomes the femoral, that's where we see the inferior epigastric and the deep circumflex artery that I was mentioning beforehand when we were talking about blood supply to different parts of the gut. Right smack dab in the middle is the median sacral nerve. And then as we go upward, we've already kind of seen these branch off points for some of these other components like our celiac trunk, our superior mesenteric trunk, and our inferior mesenteric trunk. Looking at this branch here, it really shows the branch points again well, and then the right and left commons, the internal, external iliac, and then the 3 branching points off of the aorta that are going to feed to the gastrointestinal organs, versus these dual branching points are feeding off to things that aren't gastrointestinal organs in nature. And you can see paired versus unpaired arteries. Really, your unpaired are going to be your trunks that are going to your digestive tract. Your paired things are the arteries that are actually going to the non-digestive tract organs, like your suprarenal, your renal, and your gonadal arteries. From a venous perspective, I'll go back into this slide here. From a venous perspective, we have our major drainers coming back up through. So the veins of our posterior abdominal wall, everything's going to drain back into the inferior vena cava except for one, the left gonadal vein. It's the only thing for the posterior abdominal wall that doesn't drain directly into the IVC. So that's a great question. It's like the weird cheese stands alone that doesn't do what everyone else does. Our IVC has a valve at the junction of the right atrium, but it's not functional. There are all the things listed that drain into the IVC. We can see that here, starting from our external, internal iliac veins, moving upward, all these different branch points that really follow the arterial branch points. And then these large ones being our venal veins, moving all the way up, this being our hepatic veins, and then of course as we move superiorly, eventually it will drain into our right atrium. Posteriorly, we can see that azygous vein here and our hemizygous veins. Again, that other drainage system that we've seen that can accompany kind of anastomoses with our IVC. All right. The gut, we did it. Know the general flow of food through the gut, the digestive tract. Know how the liver relates to, sorry, I'm trying to find you all again. There we go. Know how the liver relates to the gallbladder, relates to the pancreas, and those different duct structures. And then if you can understand the general branch points of the aorta, those 3 major branches, and really I'd focus on the vasculature to the stomach, the spleen, and the liver. That would be the 3 areas I'd focus on vasculature to. I wouldn't worry as much about vasculature to the other structures. If you understand generally that abdominal aorta splits into common, those common iliacs, and then the internal and external, and then femoral, that flow posteriorly or inferiorly should be enough for you, besides the major three trunks, the celiac, the superior and inferior mesenteric arteries. But I know it's a lot. That's why I encourage you to draw them out. I think that's the only way to learn these and really get them in your brain. Okay. Or use a coloring book. My favorite. All right, let's take a 10, our last 10. We'll come back at 310, and then we will go through embryology. I'm going to go through, I'm probably going to skip around a little bit. I'll start with the embryology review part 1, which goes through embryogenesis. But I'm going to skip out of a few pieces to talk about organogenesis and specifically heart development. So we won't talk about each slide equally because I'm going to skip a lot of pharyngeal pouch discussion. I'm just going to give it to you there as a resource because oftentimes it's not really tested on. It's only like every few tests that they lean into pharyngeal arches and pouches. So it's there, but we're not going to probably talk through it in detail. So we'll come back in 10 minutes and then we'll go through our last piece of the puzzle. We'll check in on strategies for incorporating this into your biochem study and then talk about what to look forward to next week, which will be, I think, more of a fun week. Hopefully we'll be back together in person. All right. Break for 10.